Our grand round speaker this morning is Kristine Krueger, who's a multi-talented person and physician. I've been fortunate to know Chris for actually over 20 years now, and I've watched her kids grow up. Alex is a junior at Purdue in engineering. Katie just graduated, and actually Chris drove down to Auburn a couple of weeks ago for her graduation, and she's going into veterinary school, and I think Chris has probably been a big influence on that. Those of you that know Chris, she's got all kinds of animals, is a big horse rider, and so I think she's really had a big impact on Katie's career. Chris actually went into gastroenterology when there were almost no women in GI, and I can't actually remember another therapeutic endoscopist who was a female. So Chris has actually been a great role model, especially for women in gastroenterology. She's going to talk today about C.diff colitis, and this is actually an incredibly important actually infectious disease topic, and it was something that when I was a GI fellow was just beginning to be understood and could actually take over hospitals. So I was at the Minneapolis VA where there was a huge outbreak. Luis Marzano was at Barnes where there was another one, and actually a lot of the original research and infectious disease detective work came out of these early periods. In fact, we had diarrhea clinic almost every day of the week where we did flex SIGs on anybody that had new diarrhea in the hospital for 3 days, because the definitive way of making the diagnosis then was doing a flexible sigmoidoscopy and looking at the pseudomembranes. So with that introduction, we'll have Chris tell us what we learned in the last 40 years.
Thanks, Craig. Thanks very much. It's a pleasure to talk to you all about management of C. difficile, particularly because I know that you're going to see it every day, and hopefully I can impart a little bit of understanding of the organism of C. difficile and also go over treatment for C. difficile. I have no industry disclosures to make. I do have some thanks to give to our hospital epidemiologist, Dr. Forrest Arnold, for one of the clinical cases, which I'll talk about towards the end of the talk, and Dr. Ashutosh Barve, who published in the KMA journal a couple of years ago a very interesting case. Key references that you might want to look at include some New England Journal articles, and particularly the one that gave us FDA approval for fecal transplantation, published 2 years ago in January. And there were some very interesting articles that just came out this month. This New England Journal article is a big review of the topic of C. difficile management. And in JAMA this year, towards the end of the talk, I'll tell you about a very exciting new study that will probably be newsworthy in the next day or two. So our objectives are to review first the epidemiology and pathogenesis, as well as the burden of C. difficile in the United States, and again, give you updates on treatment, and that will include the antibiotics that we use every day to treat the disease, as well as the antibiotics that are associated with causing the disease. Surgical treatment will only very briefly touch on. It has fallen away as being a mainstay. And then lastly, mostly on fecal microbial transplantation, which has emerged as perhaps the best option, particularly for recurrent C. difficile. I can't leave the room without recognizing Mark Pfeiffer, reminding us all that that C. difficile is our #1 nosocomial hospital infection, And so we have to really be geared for prevention measures, which is what you all do every day. So C. difficile is a beautiful organism. It's a bacterium. It's a gram-positive anaerobe. It's a spore-forming bacterium, and that's the problem. These spores are heat-resistant and they're acid-resistant. They're very difficult to kill, and they can stay alive on hard surfaces for, every time I read, it's a longer number of months, but 9 months is what I've heard. So in a hospital environment, that's all the countertops, that's the bathrooms, that's the telephones, that's the stethoscopes, that's the person's hands that are touching the patient. It's all over the place. So it's all over healthcare facilities. What burden it causes, I've already mentioned. It is the number one nosocomial infection. While most of the infections occur in a medical facility, a hospital, or a nursing home where you acquire it, there's an increasing amount, up to 25%, of community-acquired C. difficile infection. Now let's talk about this for a second because it gets confusing. We say it's a commensal bacterium in at least 2 to 5% of the population, but it's likely much higher in healthcare and daycare workers. So I have no idea how much C. difficile is in the room, but my guess is it's way above 5%. And I didn't know until I reviewed for this talk that a majority of infants, 70% or above, are colonized with C. difficile. Now, they don't get the disease, and some of the postulates out there are that their immature gut doesn't yet have toxin-binding receptors. But we do know that they are exposed to toxin-producing organisms because they make antibodies, and in later life, they may be protective antibodies against getting the disease. So again, this is a pretty ubiquitous bug, so it's not just that the organism is there. Through the talk, you're probably thinking, why do some people get infection and some people don't? The main and number one reason of rising prevalence is due to broad-spectrum antibiotic use, because we're killing the microbiota that would otherwise help protect or keep the C. difficile in a non-virulent state. And you probably read about, now it's about 8 years ago, there was an emergence of a hypervirulent strain, the NAPI1 027B1, and I read what this all means, and it would take me a half an hour to explain it. But that's the organism, and that organism is antibiotic resistant. Majority of C. difficile is not. And this one is a minority, and to my knowledge, it hasn't yet come to Louisville. It's very prevalent in Western Europe, however. The other thing is we still say we have poor infection control. I hate to admit we have poor infection control when we think we have great infection control. But keeping in mind that this organism is resistant to acid and resistant to most cleaners, alcohol does nothing, that we have to use just extraordinary sanitization techniques to get rid of it is the reason. We also have done well, you all have done well in keeping people alive longer. So we have older patients, we have patients with cancer, we do bone marrow transplants, we have many patients on immunotherapy, immunology with rheumatoid arthritis has given people quality of life, but now they're also on TNF antagonists. And so we have lots of patients, or increasing populations of patients, on immunosuppressive therapy. And that might have a role. A problem with C. difficile is it's not a required public health reportable disease, despite its importance. I don't understand that, but I don't make the rules. But so for that, we don't know the actual or local incidence rates for C. difficile. What we do know is, again, as we get older, things happen, and the cases of C. difficile per 100 discharges go up. This graph cuts off in 2010. It's continued to go like this, including at our facility. Now, remember I mentioned some people are colonized, many of us in this room, infants, etc., but who gets the disease? When you're hospitalized, you get the disease in 3/4 of cases, and maybe that's because A, you're sick, and B, you're immunocompromised, but you're getting antibiotics. But look at the prevalence rate of hospitalized patients. If you're hospitalized for 2 weeks, you've got about a 13% chance of getting C. difficile diarrhea. And if you're in here for a month, about half of you will get C. difficile infection, diarrhea, not just colonization. And the problem is, if you treat someone, again with metronidazole as our mainstay, because it's still a little less expensive, even though vancomycin is now generic, vancomycin has a little bit higher rate of reducing recurrence, but it is not superior to metronidazole in initial treatment. But the problem is, after initial treatment, the recurrence rate, if you successfully were retreated, you're going to have 20 to 25% recurrence. If you recur a second time, your recurrence rate is at least 40%, and then it just goes up and up and up. And that makes sense if you think about the microbiota and what we said at the very beginning, that you need a certain amount of microbiota and certain types of microbiota to keep your gut bacteria healthy, the integrity of your immune barrier. So more antibiotics, although they kill the bug C. difficile, kill all your other microbiota, and that's why the recurrence rate goes up with subsequent antibiotic treatments. And we're not really sure about this one, but proton pump inhibitor does double the risk of C. difficile infection. I said a moment ago the spores are acid resistant, so if they're acid resistant, then we can't say that we kill them in our gastric acid, so why would PPI double the risk? We don't know this, okay? We just know that this data exists, but it could be confounded that people on PPI are also people admitted to the hospital, or also people on antibiotics. Hope I didn't confuse you there. Mortality rates have gone up. They've risen over 400%. So people die from this disease. It accounts for 15,000 deaths annually. That's a significant number of deaths. If you consider colon cancer kills about 50,000 a year, C. diff is marching its way on up. We've already mentioned half of the infections occur in patients that are younger than 65, but most of the deaths occur in older people. And the spectrum of the disease is variable. The definition of mild C. diff is someone who's not admitted to the hospital. So there are plenty of people that I see and that GI docs and primary care doctors see in your office that have diarrhea, that have been in a healthcare facility or who've gone to a nursing home to help care for a loved one. And they may have mild diarrhea and may have mild C. difficile. Moderate and severe are defined by requirement of hospitalization because of dehydration and toxicity. With very severe disease presenting as a toxic megacolon, that incidence is low, but the mortality is incredibly high. And if you send them to surgery, half of them will die despite having their colon removed. So that's quite a serious disease. How do we diagnose this? We should spend a little more time on thinking about diagnosing C. difficile, because if our patients have diarrhea, I'm going to say send their stool for toxin and see whether or not they have toxin-producing organisms. If they are without diarrhea, it makes absolutely no sense to send their stool, because the lab will tell you they, A, can't perform the toxin assay, and B, your patient might just be someone who's colonized. And the reason I'm saying that is most of the labs have reflexed since 2009 to a PCR. So PCR amplifies the product and will definitely, with very high sensitivity and very high specificity, tell you your patient has C. difficile. You as the doctor tell us whether or not they have the disease, the infection, the inflammation. If they're just a carrier, they're just a carrier. So why am I going on and on about this? Because after you've treated your patient that had C. difficile, if they tell you they're then passing normal formed bowel movements, it makes no sense to check a stool PCR. It'll be positive for a few months in most cases because the spores are still coming through. And that will cause confusion for you and your patient. who then will say, well, I need more antibiotics. If you give them more antibiotics, then they're going to end up getting the diarrhea again, potentially, because you've killed off more microbiota. So the most recent review article in New England Journal reiterates, do not send stool for analysis if the patient is not having diarrhea, and do not send a stool PCR after treatment because it will be positive and will confuse you. So Craig mentioned in the past we had to use flexible sigmoidoscopy to diagnose C. difficile. There were actually dogs that would come into nursing homes and could sniff, and patients will tell you, I don't have C. diff anymore. I don't smell that smell anymore. I've never smelled it, and I don't know if anyone in here has, but your patients will tell you and dogs will tell you, but we don't have to revert to that or use that very often anymore. Now, CT scans, when you get a CT scan of your patient with diarrhea, a hallmark criteria considered to be relatively sensitively diagnostic and specific is if the wall thickness is more than 4 millimeter, and it's usually a patchy distribution, although it can be a pancolitis. I'll show you these pictures. Okay, these pictures are what severe colitis looks like. Now, this could be infection or this could be ischemia, okay? So what you have here is the Mercedes sign. So here's your transverse colon, and here's some contrast in the lumen, and it looks like a Mercedes, right? And because this is the wall, and these are thumbprints, which are also depicted on this plain radiograph here. The colon diameter is not supposed to be more than 5.5 or 6 centimeters on a KUB, with rare exceptions. What it looks like endoscopically, as Craig mentioned, it looks like coalescent yellow plaques that make a pseudomembrane, and histologically, here's the epithelium. And here's all this purulent debris. It looks like a volcano. In fact, sometimes you just get little pustules, and that represents that right there. Okay, so what antibiotics cause C. difficile? Well, many antibiotics will cause your microbiota to become sick so that your C. difficile that you're colonized with can become active and revert to a virulent form. And those common ones are listed here. Clindamycin we all know about for dental, amoxicillin, ampicillin, cephalosporins, and fluoroquinolones, which is a big problem. And then somewhat common, Septra, other penicillins, and less common, these gram-negative coverage. Forrest Arnold, however, our hospital epidemiologist, did a study here, because the real answer is it could be any antibiotic if you overuse it, and that's where antibiotic stewardship comes in. So he published a study a few years ago now in this organization to show that piptazo and cefepime were our two highest used antibiotics, resulting in C. difficile. Okay, so let's talk more about infection control stewardship. So what can you do? Well, you have to first know or suspect your patient has C. difficile and test for them. So you test for them if they have diarrhea, and then isolate them and notify transferring facilities. Okay, if you're sending your patient from the emergency room up to the MICU and you're admitting them with diarrhea, you need to let them know it's an isolation case. Wear gloves and gowns, then discard when you leave the patient's room before touching anything else, including your stethoscope. Don't use your stethoscope on those patients. Hand sanitizers, I mentioned, do nothing. Alcohol does nothing. Hand washing is not adequate, although hand washing studies were better because at least it would rinse the spores off of you. Surfaces have to be cleaned with EPA-approved spore-killing disinfectant, which has a high quantity of bleach. That's about all we can do. A very new technique, expensive technique, is using pulse xenon UV disinfection. And again, more importantly, think about antibiotics and reduce antibiotic use whenever possible. If you do all of these things, and there have been published reports, you can reduce your transmission rate and infection rate in your hospital by about 50%. So more work is to be done. So again, a cartoon to put together how we get C. difficile. We get C. difficile because we give antibiotics that give us abnormal or altered colonic microbiota. And then add that with other risk factors, advanced age, immunosuppression, inflammatory bowel disease. So you've got the right host, you've got the right environment, you've got altered bacteria. Then you develop toxigenic species and toxin production. And one or two things can happen when you have toxin production. You can have an antitoxin response, which is your own innate immune system, your gut immune system, other bacteria in there that will destroy the toxin, bind the toxin, and you'll have asymptomatic carriage. Or you can go on to have an inadequate response and have diarrhea and colitis. Once you're at the stage of diarrhea and colitis, you can have resolution of this if you have restoration of good bacteria. Or you have an inadequate response and you have recurrence. So that's the key point why when you have a patient recovered, that patient should still be considered at high risk for reoccurrence. And it's more important, I think, after you've treated them to protect their microbiota, and we'll talk about that a little bit later. Is Dr. Redinger here? Dr. Redinger reminds us how important bile acids are. And Rupnik published this month that there is a very strong interaction between bile acids. Some promote and some decrease, negative feedback effect, the vegetation of C. difficile spores. So you have spores in the environment and you have antibiotics, and you also have bile acids that act upon them and can help them vegetate. They attach but don't invade the colonic epithelium, and when they grow in sufficient numbers, they produce toxin, which produces the disease, which then causes destruction of your enterocytes, inflammation, leaking of protein, hypoalbuminemia, etc. We've known since about close to a decade now, with improved rapid hybridization, that we can catalog the microbial species. So now we can tell people, we used to tell people in the past, I can't culture your stool. I mean, I'll find E. coli because I know it's there, but I can't tell you what all the varieties are or the quantities, but we can do that now, and we've been able to do that for a while. And what we've learned from that is that our body has about 50 phyla, and the GI tract contains about 10, with 90% in healthy people being Bacteroides and Firmicutes, with a minority comprising of Acinetobacter, Proteobacter, Fusobacter, etc. And all told, we've got 10 trillion cells of bacteria in our body, which in an average size person is about 1 kilogram, and in a large person is up to 2 to 3 kilograms. That's 2 to 6 pounds of bacteria in our GI tract. And that brought some new terms, like eubiosis, where we're well balanced, we're in harmony with our bacteria, all is good. Dysbiosis, on the other hand, is where we have either reduced amounts, reduced kinds, inappropriate numbers of aggressive bacteria, like E. coli, etc. And we've also recognized that specific diseases are associated with reduced commensal or beneficial and more of the aggressive bacteria. And these diseases, many of them are GI, and that's why I'm talking about this today. That includes inflammatory bowel disease. Your Crohn's and ulcerative colitis patients have altered microbiota. Your obese patients have altered microbiota, leading to metabolic syndrome. And gastric and colorectal cancer may also be related to altered microbiota. Now, what do these bacteria do from the upper GI tract, where most are aerobes, to the lower GI tract, where most are anaerobes? There are specific numbers of bacteria. You might have noticed a new diagnosis called SIBO, small intestinal bacterial overgrowth, the patient that bloats a lot at the end of the day. We culture their small intestine, and if they have more than 10 to the 4 colony-forming organisms per mil, we call it SIBO, and we give them antibiotics. But these are important to be the right numbers in the right places in order to perform functions of digestion, absorption of micro and macromolecular substances, and vitamins, and water, and electrolytes, and short-chain fatty acids. Now, colon bacteria, though, isn't good in a decubitus wound, but colon bacteria is good in the colon. So you might think it's a new thing, new kid on the block, FMT, Fecal Microbial Transplant. It's not. The Chinese did this in the 4th century when patients had dysentery, and they gave it as yellow soup, and they took it orally. Veterinary medicine uses or has observed coprophagia, the act of dogs eating poop. If you own a horse, you know your dogs like their hooves and they like their poop, and it drives you nuts. But tell me a dog that's outside around a horse that ever has any disease like cavities in the mouth or enteritis. They don't. The dogs that get Crohn's disease are the ones that stay inside the house and are fed by their owners who don't want them to go outside in the dirt. So in World War II, the Germans observed the North African Bedouins ingesting camel dung also, and that led directly to research that led to probiotic Bacillus subtilis. In 1958, in this country, Eisman gave a retention enema for the first pseudomembranous colitis and cured the patient. And then Bowden did the same in 81 and 16 patients, but it wasn't until 1983 that Schwann was given credit because C. difficile was now able to be cultured. And he did this with FMT. So it's been out there a long time. One of the reference articles was a review article on the microbiota that Lawrence Brandt published in AMJ Gastro in 2013. And I could talk, and Dr. Friedland of neurology could talk also about the role of microbiota in non-GI diseases. There's emerging interest with it in Parkinson's disease, although it might not be a bacterium, it might be a virus, because there's viruses in your stool as well. So again, we know that with clinical trials now, we can improve or cure metabolic syndrome, Crohn's disease, irritable bowel, and C. difficile infection. So those are the GI diseases. But there's also a lot of interest in non-GI, and particularly neurologic diseases, using components of the stool or transplant of the stool. Currently, the only FDA-approved treatment for using FMT is for recurrent C. difficile. So if you can remember that, FDA has approved the use of C. difficile. What evidence do we have that this works? We've got a lot. Antibiotic-treated mice infected with C. difficile develop chronic dysbiosis, very similar to humans. It's way over this now, but by 2011, 400 cases, the cure rate by FMT was 91%. I will contrast that with what the cure rate is for vancomycin or metronidazole, which is about 70%, so, or even a little bit less. So FMT is superior. C. difficile recurrence after FMT, after you give a fecal transplant, is incredibly low. And it seems that the transplant persists. Maybe it's because those bacteria bind to the receptors and they know that's home, as opposed to when you have them on your skin or a decubitus ulcer. There have been no reported serious adverse events. It has FDA approved and has a CPT code. And this was the most important contribution to the literature that got us interested in fecal transplantation for C. difficile. It was halted because the cure rate was 3 times greater giving FMT than antibiotics. And I'll show you that data. It was a 3-arm study. So you had people who got vancomycin, and you had people who got vancomycin with a bowel lavage because somebody thought appropriately, hey, maybe the reason FMT works is because you're giving them a bowel lavage. So there comes the question of, are colonic lavages good? But in comparison of bowel lavage, vancomycin alone, or giving donor feces once or twice, the success rate from FMT was far superior. Now, these are people with a second episode of C. difficile. And then if you look at the microbial diversity, here's your healthy donors, and here's your patients after infusion, and here's your patients before infusion. So again, there's something about the C. difficile patient where their microbiota is altered, and the easiest way to fix them is to give them back the good bugs. The question is, after this happened, our phones were ringing. Okay, Steve McClave told me if anything else, just be entertaining. So here's my entertaining slide. our phones were ringing from all over the state. They knew we were working on FDA or getting our quote IND, which the FDA first wanted, but then they said no. All you have to have is an informed consent document. And so people were calling, asking us, could we please help them out? I don't believe they do this at the University of Kentucky. I don't think anybody else in the state does fecal transplant, but we do. The technique is very easy. It's no harder than doing a colonoscopy. The hard part is that you have to have a suitable donor, and the stool has to be fresh. Bacteria in the stool are denatured in air, so your donor needs to put it in an airtight container. They can put it in the refrigerator. They can put it in the freezer. We prefer they don't put it in the freezer because then we have to wait for thaw time. When we get the specimen and their blender, which we ask them to buy at the dollar store, and by the way, don't ever purchase a blender at the dollar store. I don't know where it might have been. What we do is we take the donor stool and we mix it with about 250 to 400 cc's of diluent, and we blenderize it, and we use gauze to remove big particles so they can get down through the chamber. You do your colonoscopy the normal way. Your patient takes a lavage ahead of time, but maybe we don't need to do that in the future. You get to the cecum and you infuse your transplant. Initially, people were putting it in the terminal ileum, thinking that would give a break, and then therefore your patient would hold this liquid stool. After the procedure, you have to lay them on their back and give them loperamide so that they can retain their transplant. Albeit every single one of them tell you they have diarrhea all the way home, and you know it's that they're getting rid of some of the transplant. So the bit about cecum versus TI, I've never wanted to put it in the TI because I'm sort of like, wait a minute, these bugs are supposed to be in the colon. If you stick them in the TI and they reflux up, could they end up having or getting or acquiring small intestinal bacterial overgrowth? And that's a possibility. So most people now are giving it in the colon. You can give it via an NG tube, though. The first New England Journal article, they gave it via an NG tube. They had a success rate of 83%. It's important, though, because maybe you have someone in the burn unit that has wounds all over and has a peg, and maybe you can put it through a peg because they are contracted, and there's something about the patient where we can't do a colonoscopy, so we have other ways of giving it if we have to, but most of us give it in the colon. So that's the technique. Now, question, though, is what about the donors? Should they be related or not? We screen donors for a variety of transmissible diseases, including hepatitis and AIDS and syphilis. And we also exclude them if they have a history of gastric or colon cancer. Question whether or not if they had prior Helicobacter pylori, since some H. pylori are associated, obviously, with gastric cancer. If they have high-risk behaviors or body piercing within 3 months, we would exclude them. And obviously, if they're a healthcare worker or they've had antibiotic use, we would exclude them as well. Less known is should you exclude someone with food allergy? Should you exclude somebody with IBD or IBS from being a donor? Now, the thing about should they be related or not is conjecture. Most relatives are the ones who submit stool, and they are very willing, and they're also very willing to pay for the screening if the insurance of the patient won't. But most intimate couples have similar microbiota, and that's why when you're with a couple for a while, you start to look alike. You might even have the same kind of physiology. However, what I explain to patient family members is, well, if wife doesn't have it or if the husband doesn't have C. difficile and you share the same bacteria, then the donor spouse probably has, they may be colonized, but they may have the right microbiota to be resistant against the infection. So most of the time it's a spouse who's the donor, or it's a family member like a young, healthy grandson, etc. And maybe you'll end up with abs like that afterwards. So we have 2 clinical cases to kind of bring the FMT point home to you. These are both real cases, and they were published. This first case was a 60-year-old that had chronic hepatitis C and alcoholism, and he was diagnosed with renal cell carcinoma. His hep C and alcohol abuse were in the past. And so his pre-admission labs had normal albumin. He wasn't a sick guy. He was electively admitted for nephrectomy. Post-operatively, though, he had some problems. He got hypoxic. He got acute kidney injury. He came down with another hospital, or maybe not, acquired infection, MRSA, and so he got strong antibiotics, linezolid and levofloxacin. On hospital day 6, he developed profuse diarrhea. It was positive for C. difficile, toxin A and B. He had a very high white count, which many of these patients get. He was hypotensive, tachycardic. He was obviously sick. His abdomen was distended. He had hypoactive bowel sounds, and the CT looked much like the image I showed you with multiple fluid-filled and thick-walled bowel loops. So colorectal surgery was consulted for emergency colectomy, which is considered the standard of care in this patient. What happened? Okay, so he had pseudomembranous colitis. He had his elective nephrectomy, and then he had his emergency colectomy with ileostomy. Sometimes they'll do an ileostomy and gavage the rest. If they don't do a total colectomy, they'll gavage the remaining colon with vancomycin. He continued on double therapy with metronidazole and vancomycin, but just remained septic and was eventually made a do not attempt resuscitation and expired on day 23 of his hospitalization. The surgery was expertly done. The surgery wasn't the issue. The disease is the issue. Our clinical case, too, is a 75-year-old female. She also has a liver disorder, NASH cirrhosis. She has ascites, recurrent C. difficile because she's been in and out of the hospital for fluid management, and she's been on antibiotics for SBP prophylaxis, and she's now admitted with greater than 10 watery stools, profound weakness, a tender abdomen, but no rebound. She's also febrile, hypotensive, and tachycardic. Her white count is elevated. She has acute kidney injury, and she has also featureless loops of fluid-filled bowel, but no free air. She was appropriately treated with oral vancomycin. Remember I said it's equivalent to metronidazole, but may have a slightly less rate of recurrence. She got both because she was sick, so she received IV metronidazole and oral vancomycin only works orally. She got Florastor, and that's important because maybe it's going to help restore the gut microbiota. And she also got cholestyramine. Remember I said a while ago that bile acids have a lot to do with maturation of immature spores. It's not just that it binds the toxin, it actually interacts with the bacteria. So she got all that good treatment, but despite all of that, she remained ill. She remained clinically ill. Her stool that was initially positive was now negative, but I don't care. Right? The toxin was negative, but you don't care if the person is still sick because there may not be enough detectable toxin for the assay. If you did a PCR, it would have been positive. She had pseudomembranes on FlexSig, which was done to confer that she still had the disease. So she was tried with fidaxomicin. As you know, it's a macrolide antibiotic, and it has been useful because of its spectrum of activity in recurrent C. difficile. She continued on her probiotics and continued on the bile acid binder. All appropriate good care. Colorectal surgery was also consulted on her care. She didn't look quite as sick to them as the gentleman, and she had some comorbidities that they thought would preclude surgery, so they said just continue doing what you're doing. Well, what's the next best treatment option? Dr. Barbe got brave, and we've gotten our approval for FMT. And so he performed, for using her husband as a donor, the first FMT here over at Jewish Hospital. And the lady got better in like 3 days. And in fact, she was ready to be discharged in a week, and her C-scope was normal at 2 weeks. We don't repeat C-scopes now, and since that time we've done more than 24. The age ranges in our patients that we've done is 21 to 87. And all of them have been females except 2, and I had the 2 males. So the problem is this one big crapshoot, again, no pun intended, but there is still potential disease transmission. Again, if Dr. Friedland is right, maybe viruses that could give you neurodegenerative diseases. We don't really know what to do with donors. The FDA does not want you to use an anonymous donor. In fact, you have to either know the person or the patient has to know the person. And we don't really know if this is safe in critically ill patients who may have disruption of their gut integrity, and so maybe they'll become more septic, and we don't really know what to do in immunosuppressed patients either. Future challenges include, should we give it orally? If firmicutes are required for germination factors in the upper GI tract, that's where those guys live. Should we give it rectally? That's where I think we should give it. And then if Bacterotherapy are the component that's important. It would be better if we could identify the beneficial components in the fecal transplant to match the donor microbiota with the recipient's disease. So maybe one day we'll have a fecal yogurt, we'll have figured it all out, or instead of giving your bone marrow for your own autologous transplant, maybe you can give some stool and freeze it and then come back later if you ever get C. difficile at the end of your life. The new buzzword and the thing that's newsworthy is now it's not considered appropriate to call it fecal transplant. We're now calling it Bacterotherapy. And I find that this is a fascinating, if you can remember anything about this talk, this was a fascinating study just published a week or 2 ago in JAMA. They found a non-toxigenic C. difficile. They figured, hey, why don't we get a good C. difficile that might bind to the same luminal receptors as bad C. difficile. So they found a non-toxigenic strain, and they decided that they were going to see if they could colonize volunteers. This was a dose and duration study, so they had various doses of an orally administered spores. And they had 173 patients. This has been going on for a while in the United States and Canada. Patients were either initial or first recurrence of C. difficile to be enrolled. So again, they gave several doses of spores for a week or 2 weeks, and then they analyzed their stool to see if they were successfully colonized, and then they followed them to see if they had recurrent disease. And this was what was interesting. Recurrent infection was markedly reduced if the subject was successfully colonized with the non-virulent strain. 30% versus 11%. So there's an idea of targeted therapy. Let's find a good C. difficile. Immunotherapy trials that we have, you've probably heard that there are vaccines that are being developed, but it's going to take about 3 years. They're in phase 1 or phase 2 trials now, and it's going to take about 3 years to see if a vaccine is helpful for primary or secondary, or if it can lessen the severity of the disease. There's also another new kid on the block that you've seen that we use for enteritis, and it is a serum-derived bovine immunoglobulin. It's IgG. And it's a medical food that was approved through the Orphan Drug Act, and it might help with our diarrhea patients by improving barrier function, providing immunoglobulins, maintaining gut homeostasis. And we're already using it for a variety of things, including persistent C. diff or persistent Crohn's diarrhea despite resolution of inflammation on endoscopy. We don't know what role it might have in C. difficile, but I can tell you there are clinical trials pending. Many of us believe in probiotics and gut health. They do good things. So I didn't have any conflict of interest except to tell you that my favorite yogurt is this Greek Gods yogurt, and it has a high quantity of a high variety of probiotics. American yogurts are simple to grow, and many of them don't contain the good type of probiotics. They rapidly form with about 4 types of lactobacilli. But for the gut, you need the bifidobacilli, so you need the Greek yogurt. However, even though we give people probiotics even in the hospital, unfortunately, either the studies were not successfully powered, but there has been no convincing role that you can use this as a prevention. unfortunately. I say, though, be kind to your microbiota. Dr. McLean says don't feed it too much alcohol. That does change. It decreases your Bacteroides and firmicutes and increases your aggressive bacteria. So, only summary slide you have to remember is how do we treat this? 1, stop the offending antibiotic as soon as possible and avoid antibiotics in the future. So after you treat your person with C. diff, tell them don't take antibiotics for months, please. After you give a fecal transplant or you give a spore or you give a pill that contains probiotics, etc., tell them don't take antibiotics. The treatment, if you're infected, is still standard of therapy, 10 to 14 days metronidazole or vancomycin. Higher doses and duration are combined for up to a month if recurrences, and or switch to fidaxomicin, 200 milligram BID for 10 days. Probiotics, you're either in the probiotic camp or you're not. I think the cumulative evidence will show that they are beneficial, and certainly after your patient has been infected, we send them all home and tell them eat Greek yogurt or take probiotics. Cholestyramine, remember, will bind both the toxin and may also help you not develop or germinate spores that are coming through from your environment. We didn't talk about IV immunoglobulin. It's only used rarely for immunocompromised hosts, but I did mention a bit about oral immunoglobulin therapies coming out. Surgery is becoming not necessary, hopefully, if we cure people. And FMT for recurrent infection is emerging as the best choice. So I stole this from an article. Hippocrates did say that all disease begins in the gut, and Dr. Larry Brandt says maybe he would say today health is determined by the microbiota in our gut. And I say, depending on your status, you may or may not want to eat the yellow soup.